2. So we are going to begin our session. Good evening, everyone. My name is Magda Scanlon. I'm a manager of volunteer services at Advocate Good Shepherd Hospital and Advocate Lutheran General Hospital. Today we are out of Good Shepherd sharing with you information about careers in imaging services. So welcome to our first virtual healthcare career series, and I hope you find that information interesting and engaging, and you find answers to the questions that you're looking for. Just a few housekeeping items. It is going to be a recorded session that's going to be available on our YouTube channel. I am going to share that information with you in the chat box. The format of the presentation is going to be a group of speakers from our imaging services talking about careers in the field. We are going to be sharing a presentation, and at the end of the event, we are going to have a Q&A session through the chat box. If you have any questions as we are going through the presentation, feel free to type them in, and we will get to answers at the end of the session. We are planning for about an hour and a half, but this is the first time that we are doing it. So based on how long the discussion is going to be, we may end up a little bit earlier, but we promise not to go past the allotted time. So I'm going to share the screen and I will invite our speakers. So here we go. And our presenters are going to be today Meredith Johnson, who is the manager of imaging services, and her two supervisors, Anastasia Buckles and Sarah Skinner. So Meredith, I am handing it over to you and the floor is yours.
Thank you. Are you going to go? Great. Hi, everybody. Welcome and thank you for joining. We're excited to kind of share some information about our amazing career. Of course, I'm going to say that, but I'm sure most of you are probably familiar. Imaging services, radiology, medical imaging. If anyone's ever had a chest x-ray or an x-ray of their finger or foot, a CT scan, ultrasound maybe, that is all part of imaging services. A lot of times in some areas, people call it radiology or medical imaging, but it is imaging services. We provide care and imaging for patients, for procedures, for testing, a whole, you come in with a cold, we might do a chest x-ray. So what our position and our career does is it helps with the physicians to diagnose and treat their patients. So we're going to give you some background on how we got where we did and kind of everything that we cover. So we hope you find it interesting. So most of us, we are radiologic technologists. And sometimes people call us x-ray techs, RTs, radiographers, but all of those are the same person. So a radiographer is someone that goes to school and learns about radiologic technology. And there's a lot involved in it too. It's a college degree, or associates, or it's a bachelor's. Areas of interest that are different areas that you can study either in your 2-year or 4-year program or afterwards is we have MRI, CT, computed tomography, interventional radiology, cardiac cath lab, mammography, nuclear medicine, ultrasound. Some people get into the medical dosimetrist and radiation therapy. Though a different program, we do have other imaging team members that help kind of round out everything that we do, and that would be our imaging nurses. And we do have clinical techs. Some people call them certified nursing assistants. So there's a lot of people that affect how we care for our patients. Also in imaging services are our radiologists. They are physicians. Obviously, they have a 4-year degree, a medical degree, or a doctor of osteopathy. And then they go on to do the residency for 4 years for diagnostic radiology. Some of them also go into specialized areas for a fellowship. So they can do interventional, mammography, radiation oncology. But the radiologists, they help perform some of the exams. They help build the protocols. So if someone comes to the hospital and they need, let's say, a CT of their chest, the radiologist and the technologist have a protocol specific to why they're needing that chest CT. So it's a big group of people that work together to ensure that we've got all the right information to help that ordering physician. So what we're going to do now is we're going to touch base on some of, we call them modalities, but some of the areas within imaging services that encompass everything we do. So radiographers is what everyone is considered. You work in general X-ray, which is, if you notice, it says X-ray technologist. The technologists operate the X-ray equipment. With that, if you see the top picture to the left, that is someone taking an X-ray, probably of the spine. If any of you have ever had one too. So often we need to visualize the body for emergency surgical cases, falls, injuries, things like that. So what it is, it's a two-dimensional picture. And what that does, that picture is going to help diagnose, and it will help treat any type of injury or illness that you have. A lot of times people start with just a general X-ray, and then they move on to like a CT or an MRI after if they need more advanced imaging. The middle picture is a CT technologist. A CT technologist is cross-sectional anatomy, so they create cross-sectional images. So if you can visualize, let's say, a loaf of bread, and then taking one slice out, that is cross-sectional. So that's what we do with that. It's advanced imaging, so it shows more tissue and bone and organs and blood vessels. Again, it's for emergent interventional trauma. It's usually probably the next step after an X-ray to see what they can do to help visualize and help diagnose the patient. Interventional technologists, or we call it IR, that's another area that you work hand in hand with the radiologist. They do interventional procedures. So an example would be a vascular procedure for like a blood clot. They would go in and they would kind of take an instrument and they go retrieve that blood clot. So it's more invasive procedures. Interventional radiologists work also with our CT team for biopsies. So someone needs to have a biopsy, whether it's no matter what part of the body. So it's just another advanced area in imaging services that the technologists go into. So here are some pictures. I wanted you guys to see some general pictures. This is X-ray, the 2D. So you can see a picture of the skull, the spine, the chest. The one to my right is that's a picture taken in surgery. A patient had a hip replacement and it popped out. So that's part of the pelvis. And then the one at the bottom left it's called an orthopantomogram, but most people might know it as by a mandible. That's a picture. Sometimes when you go to your dentist, they're going to take it to the dentist's office. They're looking at the mandible, the bone that your teeth are settled into. And the bottom three pictures are part of our equipment. So in order to get the imaging here, you have to take a picture with a piece of imaging equipment that gives some ionizing radiation in order to give this picture. The one on the left is a portable unit. Oops, sorry. That's a portable unit. So a lot of times we have to go to the patient versus the patient coming to us. So most people, if they have to go to the hospital, they might have an appointment or they go through the emergency room. We do have patients that are up on the floor. So they're unfortunately maybe not well enough to come down. So we bring the X-ray to them. The middle one is the units that we have in the room. So if a patient comes in for a chest X-ray, if they have to lay down for, let's say, that lumbar spine picture, that's what the unit looks like. And then the one to the far right is called a C-arm. We use those mainly in surgery. So we're assisting a physician in the surgery suite while they're doing, let's say, maybe a hip pinning or they're doing a cholangiogram. There are a fair amount of surgeries that require the imaging to help guide that surgeon through the procedure. So the nice thing about general X-ray here is that you are all over the hospital. You are in the inpatients, you're outpatients, you're in surgery. There's a lot emergency rooms. So it's a wide variety of things that you get to see. Next slide. So this is CT. A lot of people call it CAT scan, but it's computed tomography. I gave you kind of an array of pictures. If you notice on the top, you're going to see a picture of a head. And I put those in particular because there's different types of cross-sectional we do for those images. There's a picture of a patient up there that has a small bleed on his head. If you notice, there's probably some, I don't have a pointer, there's a little bit of whitening of the brain. That's a bleed. And the next picture shows you don't see your eyes. It's a tissue, soft tissue, but there is the orbital socket where your eyes go. So it's kind of interesting. You can see your sinuses in there too. The middle picture is showing an abdomen. So we've got pictures of your liver, your kidneys, your heart, your abdomen, or your colon. So that is a cross-sectional picture of what your abdomen looks like. And then some of the pictures on the left too are some other post-processing we do. So we do a lot of 3D or 4D technology. That one picture of the lower spine, your lumbar spine, is a 3D technology. So we kind of reconstruct. This helps physicians, especially orthopedic surgeons, to help when they're looking to maybe do replacements or some type of surgery. And then if you notice the bottom right there, that is a CT scanner. They've definitely evolved since I got into imaging several years ago. They are unlike an MRI, but like an MRI. They look like an MRI, but the exam is not as long, and you don't. Some people get a little claustrophobic in an MRI. A CT is much different. And then the middle one at the bottom, I don't know if you can see it, but that is a CT of a knee, and the top of it is a patella. So and then the next one is some lung. So I just wanted you guys to see the difference with a cross-sectional versus a general X-ray. And then of course, not to say that we X-ray humans, but you can also do X-rays on animals. If you see there's a horse over there. So there's a lot of university hospitals, there's a fair amount of technologists that will also work in the animal industry. So a lot of big universities that have veterinary schools, they have the same kind of equipment we do because they do the same procedures on animals. So that is a horse that's going to have a cervical CT scan done. So there's a wide range of different areas that you can kind of go into. Next slide. And then the last one I'm going to talk about is interventional radiology. So this is what I spoke of about when it's the technologist radiographer will go in with the physician and work side by side. The rooms are more of a sterile type of procedure, like if you were going in for surgery. Vascular. So there's the picture of the equipment we would use to go retrieve like a clot. A neural, they do a lot of clots for patients that might have had a stroke or carotid arteries, things like that. So it's much more invasive, a lot more emergent patients will go see them. So it's again, another area within imaging services that the radiographers can get into. I'm going to have Anastasia talk about some other modalities.
Hi, I'm Anastasia. I'm the supervisor of MRI, ultrasound, and CT here at Good Shepherd, but I am going to be talking first about MRI. It's magnetic resonance imaging. MRI uses magnets to realign your hydrogen atoms in your body. Then after we align all your hydrogen atoms, we release them, and as it cuts across a receiving coil, we can tell the differences in types of tissue. MRI is differently detailed than CT. It's more for soft tissues. We do it a lot for musculoskeletal when people have knees, elbows, hands, wrists, anything like that. It is also used in an emergent fashion when patients come in and have potential strokes. MRI will be used to diagnose the extent of that stroke, how bad it is, what particular area of the brain it might be in. One big thing with MRI is the number one thing with us is safety. We always screen all of our patients for any type of metal they've had in their body, be it through surgery, accidents, injuries, metal in your eyes, anything at all like that. Safety is the number one important thing there, because any small bit of metal that gets into our magnet, it's going to be greatly attracted to it. Mammography is another type of technology that is used. It's utilized specifically for breast imaging. It is using X-rays as well, but it is a specialized type of modality just for that. Most of the time, women come in for their mammogram and they will have same-day results with their radiologist. If there's anything of question in there, they try to get those results done as rapidly as possible to get those patients taken care of in a timely manner. They also do imaging. We do a lot of magnetic resonance imaging after mammography. If a woman has a dense breast and they're not able to see the area under ultrasound, they'll go to MRI. We do biopsies in both. Biopsies where we, again, it's similar to CT where we're taking an instrument and getting a sample of tissue from an area and then testing that sample of tissue for any pathology. Ultrasound is another type of technology. Ultrasound technologists specialize in sound waves. They use sound to create their images. They have probes that they put onto the abdomen and that sends sound waves into the patient. The sound waves will bounce off tissue and come back to the receptor and create images for them. Ultrasounds are the eyes of the doctors. They have to press in more if they can't see something. They really are the go-to for the radiologist. Ultrasound also uses their sound waves to check on the flow of blood through vessels. There's a lot of, they check for blood clots up on the floors. And in patients with DVTs, they're constantly doing emergent situations. Actually, can you go back to that last one?
Oops, sorry.
I'm sorry, you're fine. The ultrasound technologists have been instrumental with the COVID patients. They're constantly going into the rooms and finding all of the blood clots, ruling out blood clots in those patients. All of the technologists have been great with everything that's been going on. Our hospital does require us all to wear personal protective equipment. Everywhere has safety procedures for their technologists first in mind with everything. You can go to the next one now. These are some pictures of MRIs. The top left is the 3 sections. We always do everything in 3 planes in MRIs: axial, sagittal, coronal, just so they can get a 3D view of everything. They can also locate things in different areas of the brain. With certain other imaging, with it being flat, they can't necessarily tell where it is. This helps to determine where things are specifically. Under that is an MRA of the brain. It's blood vessels, so we can tune our magnet to just do the flow of vessels, and then that's where we would see if anything was occluded, where a patient might be having a stroke or anything like that. The next over to the right is the knee MRI. Again, musculoskeletal is big. You can see all the tendons and ligaments, all of the muscles and soft tissue. If there is any damage, they're able to see any swelling, fluids in there, any torn ligaments. Below the knee is the wrist. Those are all your carpal bones. Again, that is checking ligaments, tendons, everything that runs through those bones and could be affected by any breaks, small fractures, anything at all like that. Upper right is an abdomen MRI. Again, liver, kidney, spleen. We do abdomens as well to check on the severity of different pathologies. If someone has liver cancer, we can see how big their mets are. We'll often do 6-month follow-ups to see if they're growing, if anything's changed. A lot of our patients, we unfortunately will see routinely over the course of a few months as we're checking on the progression of their diseases or the betterment of them. Last one on this is the lower right hand. It's a MRI of a cervical spine. You can see all of the vertebrae, and then the dark the dark in between is called a disc. This one has a protruding disc out the posterior of the spinal canal. So this could be causing this patient pain. When we do all of our imaging, it is the technologist's job to be the eyes of the radiologist. All of the pictures we're submitting to them, they're reading out. So if we clip something, don't get all the anatomy on there, that's what they're not going to read. So we really need to be critiquing our images and making sure that we have everything necessary on there for them. Next one. Okay. Ultrasound. The upper left-hand picture is an ultrasound technologist with the probe. That is what you push onto people's. That is what you push onto people's abdomens. Next to her is a picture of a baby. There's the profile of a face there. Ultrasound is used. Most commonly, people associate it with pregnant women and looking at babies, but it is used for a lot of other imaging. To the right of that is a picture of a vessel. This is an ultrasound where they're watching the blood go through those vessels, and they can tell if there is a clot or anything in there because they can see the decrease of blood flow. Lower left is a kidney. It's kind of like an oval, and then it has kind of some white in there. That is your renal pelvis. That's where your kidney connects to your ureters. So they're checking on the connection of that and also the state of the kidney. To the right of that is again another flow study. The image on the right-hand side or the left-hand side of that is the regular image. And then the right-hand side is where they've applied the flow to it. So they're checking on the vessels in that area.
We're going to hand over to Sarah Skinner to talk about the next modalities.
Hello, everyone. My name is Sarah. I'm the supervisor for nuclear medicine, PET CT, and X-ray. I'm just going to tell you a little bit about being a nuclear medicine technologist. What makes it a little bit different than the other imaging modalities we talked about is we're actually looking at a system in motion. We use radioactive materials that are either inhaled, swallowed, or injected, and we're studying a specific body system. For example, we might inject a patient to see if they have impaired blood flow to their heart and to see if that impaired blood flow could be improved with utilizing a stent. Sometimes we can do a nuclear medicine study to see if a patient has a blood clot in their lungs. The patient may not be able to tolerate iodine contrast with a CT scan. So they'll utilize the nuclear medicine one as a gentle alternative to figure out if the patient has a blood clot. Another area of nuclear medicine is PET CT, which is positron emission tomography. And we couple that with CT. So they get an overlay of the anatomy from the CT scan and also the molecular imaging from the PET part. So what is unique about that is if a patient's undergoing chemotherapy, we can tell real time if the chemotherapy is working to shrink tumor cells, which is, it's a very fascinating area of nuclear medicine because they're looking more into what does the scan look like and how can we treat the patient utilizing those scan results. So that's kind of an exciting area to be right now. We work closely with radiation therapy. In fact, at Good Shepherd Hospital, we share the department with the radiation oncology team, and that includes a therapist, dosimetrist, and physicist. And what the radiation therapist does is they use radiation beams to treat specific areas with high doses of radiation to shrink the tumors. And that can either shrink them until the tumor is no longer alive or shrink them enough so the patients aren't feeling any discomfort from the large size of that tumor. We also do radiation therapy in the operating room, which is kind of cool because they place a radioactive probe right next to the tumor while the patient's asleep. And it's the only time during the patient's treatment that they can get close enough to the tumor to radiate it without affecting any areas of healthy tissue around that. Next slide. These are some images from nuclear medicine and PET CT. So the upper left-hand corner would be a typical nuclear medicine camera It's kind of like a sandwich. And the gamma camera, how that works is when the patient has the radioactive tracer injected, the patient's giving off gamma rays, and those are collected by crystals inside the camera, and they're converted to an image. Some of the images you see in the top middle is a PET scan. On the left is a CT, which we utilize to kind of get an outline of the anatomy. The middle one is the PET scan. And as you can tell, it's not very helpful. But when you fuse the two images together for the PET CT, you can see areas of abnormal activity. So you can see in the lungs, there is one really bright mass. And then there's also one, looks like just below the kidney. So the scan is very sensitive to picking up abnormalities. On the upper right-hand side, it's just a scan of the brain. And this one looks like it's trying to pick up plaquing, which can be caused or can show if the patient has Alzheimer's disease. And then one of our more common scans, right in the middle with the four skeletons, that's just a bone scan. And it utilizes the body's bone cells that pick up a radioactive phosphate that gets trapped into the bone cells. Areas of abnormal activity would be if a patient had an infection or tumor, the turnover rate of the cells in that area pick up more tracer and it will show up on the scan. Arthritic conditions can also show up on the bone scan. A patient might have a cavity that can show up on the bone scan. So it's a very sensitive scan. It's just not that specific. And then to the lower left, it just looks like the pixelated one is kind of a flow study. So we can look at the blood flow to a specific area and look at the uptake in the kidneys to see if there's anything abnormal with maybe obstruction in a ureter or a kidney that's a lot larger than the other one. And then just above that is a combination of, it looks like a fused PET picture, and then the images that look like upside down V's and backward C's. Those are all myocardial perfusion images. And what we're looking at is a difference in the blood flow between a patient at rest or under normal conditions to after they had maximal blood flow to the heart. And we're looking to see if there's areas that aren't perfused or getting enough blood flow. If there's a mismatch between the rest and the stress, then usually those areas of lower blood flow can be treated with a stent. If the areas don't have blood flow on both rest and stress, oftentimes the patient has a fixed defect, which means that it cannot be repaired. And it's usually caused from a heart attack where it's actually damaged the heart. Next slide. Radiation therapy. So the left-hand side is a mask that's created for the patient, and then it specifically guides the radiation therapy beam to a specific area. I can't tell what is being treated. The mask is very common, and it also immobilizes the patient's head so they don't move, and then they can maintain that position over time, because the radiation therapy treatments are typically a couple times a week over several weeks, and they want that patient in the exact same position every single time. And the middle picture is a linear accelerator, which is delivering radiation beams to the patient. And the picture to the right is the same thing, but a different view without the patient on it. Next slide.
So and we can all talk in this one too. So we just want to give you a background on all the different, imaging services, but there's so many different varieties of things that we do in imaging. It's not just a chest x-ray or something else. I mean, it's just a wide range. There's different ways or different programs for you to go in to be a technologist or radiographer. To get into the radiology program, there's two programs. There's an associate program, which is 2 years, which gives you an associate degree. And then there's also a bachelor's program at a 4-year college, and you get a BS in it. It's very similar to a nursing program. Nursing, you can go 2 years or 4 years. Obviously, ours is, we're not nurses, but it is similar. The programs are a 2 or 4 year degree. I also want to note, though, that when you become a radiologic technologist and you do one of these programs, you can also bypass the radiologic technology program. And there's only a few areas that you can go to school specifically just for them. Meaning, so myself and Anastasia, we are radiographers. We can do CT, MRI, ultrasound, interventional. We would need to take an additional courses or year of school to do nuclear, ultrasound, and radiation therapy. Sarah went to a program that was specific to, she went to a 4-year college, but then a specific program to do nuclear medicine. So the opposite is for her. So Sarah could not go and do X-ray, CT, MRI. She's specific to nuclear medicine and PET CT. I hope that's kind of clear. So nuclear medicine, ultrasound, and radiation therapy do have their own separate programs, but you're specific to those areas of interest, if that makes sense.
And bachelor's also isn't the top of the plateau with imaging as well. You can get your master's in science. There's a doctorate. So you can progress on beyond just the associates and bachelor's if you so choose. And become a radiologist, and you can be a doctor too.
Yeah. I would say if it's something that anyone's ever interested in when you're in high school, the bigger classes you want to take, what in imaging for is anatomy, physics are two of the huge, probably our everyday job. I mean, anatomy and physics are a big thing, but in the classroom, besides the clinical training in college, it's anatomy, pathology, patient care, medical ethics, radiation physics and protection, image evaluation. When they talk about that too, a lot of it is positioning. So when a patient comes in to have an exam done, yes, we need to know their anatomy and cross-sectional anatomy, but we also need to know how to position them on our equipment to ensure we get the anatomy. Not everybody just lays flat for you. You have to be creative on some patients. So those are the kind of the bigger things to expect to study that.
And then another thing to consider when you are looking at a school is accreditation. You want to make sure you're going to be accredited with your curriculum. Accredited schools have professional associations. You can look into that online. The ART, the American Registry for Radiologic Technologists, is one of the larger ones. You want to make sure that you're going to be able to be hired with the education you're given.
Next slide. Upon graduating, so no matter what program you decide to choose from, when you graduate, you're going to take your boards. Again, I'm going to compare it to like nursing. They have to take their boards. When you pass your boards, then you become a registered radiologic technologist. So everyone will become an RTR, we call it. When you go into another modality, typically you might go into another modality like CT, MRI, nuc med, ultrasound, maybe a couple years down the road, just because the first year you're fresh out of school and you're kind of learning more of your anatomy, because you always learn more while you're doing it versus in school too. It's a program where you have to be credentialed in. So if you want to go into CT, let's say next, you're going to have a requirement on a certain amount of exams to do or courses that you take. And then you take your CT board. So everybody has boards. So you're certified no matter what area you go into. Example, Anastasia is certified in radiology and in MRI. I am certified in radiology and interventional radiology. So there's different boards depending on what areas you want to get into. So when you have your accreditation, the biggest thing with technologists is that you have to have continuing education. Similar to nursing, our education is required every 2 years to renew your license. You don't keep up the education, you can't renew your license. Every state has different requirements, but most states have this requirement. The one other requirement in the state of Illinois is IEMA, Illinois
Emergency Management Agency.
excuse me.
And that's just to license you as a person using radiation, because radiation is considered a hazardous material. So you are working with that every day, day to day. Again, you do have safety in place. And one of the things you do learn when you are in school too is radiation safety. Again, with safety being one of the most important cornerstones of all of our imaging here for our patients and ourselves.
I'm going to give you an example too. If you've ever been on a plane and you fly from Chicago to Japan, you probably get more radiation on that flight than you would coming in for a chest x-ray. So it's things like that that you're taught in school, and you understand precautions, and there's different requirements that we are to protect the patients and ourselves. We're monitored, we're badged, but without the radiation, we wouldn't be able to help to do the things that we do to help diagnose our patients. And I can tell you over the years, technology has just advanced our abilities to use less dose and less radiation for exams compared to what we did 10 or 20 years ago. So it keeps advancing, which is amazing too. You can go to the next slide. So this is kind of an example of where all the technologists are and what they're working. 60% of the technologists work in hospitals. Obviously, that's one of the bigger employers and where most patients go when they need certain things done. 19% physicians' offices, a lot of orthopedic surgeons, a lot of cardiologists, and a lot of OB-GYN physicians have sonographers or ultrasound technologists, technologists, and nuclear medicine staff work in their office. Outpatient centers, a lot of outpatient centers that might have like an MRI unit or they're affiliated with a hospital, there's 7% of the technologists work there. And then down the road, there's a few other areas too. The next one gives you kind of what the median pay and growth is. If depending on which modality you're interested in, that's kind of what the median salary is for that. And then on the other side gives you what the growth rate is. Imaging is a highly sought after area of a career interest. It's busy and it's continually growing. And I'm going to go back to the technology and just the advancements and the things that we are able to diagnose compared to what we could 10 and 20 years ago. So as technology gets better, the careers get better too.
More interesting.
Mm-hmm. You can go to the next slide.
All right, a day in the life of the department. I have worked in X-ray for about 6 years, and then I did about 6 years in MRI after that. I am newer to my supervisor position, so my day in the life was just a few months ago. One of the main things you do is validate and document. You're looking at all of the patient's orders, reviewing them from their ordering doctor, making sure that they're appropriate for the diagnosis code that they have. Some doctors, when you go into your general doctor, aren't specific to imaging, so they don't know the specifics on what they're ordering. So you as the technologist have to know what's expected of you, what your protocols are for your hospital, what your radiologists want for specific diagnosis codes. After you verify everything, you also document. You talk to the patients, you ask them what's going on, if they what's going on that they're having the scan, if they have any recurrent issues like that. You are documenting all of that in the medical record for the radiologist to read so they can look at that before they read out the images. Another huge thing is just explaining the exam to our patients. A lot of patients come in and they have no idea what they're having done. They've never had a medical imaging test. They have never had an MRI, a CT, anything like that. So a lot of times putting the patients at ease, just explaining what you're doing, let them know what's going to happen as they're going into the machine, what's going to happen as they give contrast. How long they're going to be in the scanner. CT takes about 5 to 10 minutes, where MRI can take 45 minutes or an hour, depending on the scan. So just giving them the information that they need to prep them for their scan. Again, assessing patient needs and working with the patients to ensure their comfort and care. Like Meredith said, we are doing patients that are coming in from the ER. We are doing patients that are in-house in the hospital, ICU patients that aren't always just going to lay flat there for you. They may have specific needs. You have to position them a certain way. They can't lay on a certain appendage. You have to be able to get your pictures while working with all of that patient's special needs. Another thing that we do is starting IVs and injecting contrast dye. That is, CT and MRI does that on a fairly regular basis. Nuclear medicine injects as well. That's another thing that you have to, again, be validating and documenting. You have to check if that patient has any sort of allergies, if they are pregnant, anything like that, before you give the contrast dye. Throughout the day, we are coordinating all of our schedules. I have MRI procedures. We'll have breast biopsies, sedation cases where the anesthesiologists come over from the OR to sedate our patients because they're claustrophobic and they can't make it through the MRI. So we're coordinating those patients along with our outpatients that come in and are regularly scheduled, our emergent ER patients that come in. We never know when we're going to get one. They'll just come in, and we need to make their procedures happen as soon as we can, and make ourselves available and switch around and kind of play Tetris with our patients a little bit the best we can. And we have to make the decisions on triaging our patients, who's going to be next, who's the most important, who's the most vital that needs to be taken care of. While we're actually doing our scans, one of the most other important things we do is evaluating them. We are the radiologist's eyes. If you give the radiologist a bunch of blurry pictures because your patient's been moving, they're not going to be able to evaluate those images properly. They won't be able to make a proper diagnosis. You need to be checking your images as you're taking them, and then if they aren't quality, you need to go back and either redo them, talk to the patient, see if they can hold still, what's going on. But it is your job to be supplying the radiologist with the best images possible. We also work with other modalities and departments to coordinate care. When we get that patient in from the ER after we do their CT, they'll be given, if they're potentially having a stroke, they'll be given TPA in the ER. After that, they can go to the ICU and be evaluated. They might be scheduling interventional procedures on them the next day to take care of them. So everything kind of depends on imaging. Doctors really rely on us to make their diagnosis and then determine what they're going to be doing from there and what course of treatment they're going to be taking with their patients.
Next slide.
This is
So,
our. Mhm,
oh,
go ahead.
sorry. I just wanted to wrap up just to thank Sarah and also Anastasia for this too. You can obviously tell we're pretty passionate about it, but it's an amazing career. It's definitely a critical thinking, type of career to be into. You have to have a love of science, a love of anatomy, a love of people. It's because you're going to find people that are coming in, they're petrified because they don't know what they're here for. So there's always critical skills with that. So it's very rewarding. It has its emotionals, as anything in healthcare does. A patient comes in one day, happy, and they leave not knowing that we might know something that is going to alter their life. So there's a lot of the patient care involved in it too. And but again, it's very rewarding. We love what we do. We love our patients. We have a great team here. And again, there's just so many. What's nice about imaging, and everyone has their place where they want to be, is that there are so many other avenues you can go into at being a technologist. There's so many different areas. The choices are yours. You have so many opportunities, which is most of the reasons why all of us got into it.
Thank you so very much. So I see one question. So it's a question about the median pay. Is that based on a bachelor's degree or associates?
The median pay is going to be more based off of experience. I can tell you that a bachelor's and an associate's, it's bachelor's and associates is more based off advancement. You have a minimum, you have to have an associate's, and then you have to take your boards. The median salary is based off of length of work. So if you're fresh out of school, you probably will be a little bit at the lower end of the range. But having a bachelor's is also going to help you with advancements. So if you want to become a manager, or if you want to become an executive director, or if you're looking to become a vice president, you're going to have to do a bachelor's or a master's and onto a doctorate. So it just depends on where you want to go. Now, I can't say down the road, like in nursing, same thing. You can have an associate's, or you can have a bachelor's, same process. The pay is going to be the same, but it's about your advancement.
Thank you. Another question, what are some of the most common misconceptions about radiation therapy?
Oh, this is Sarah. I can take that one. For radiation therapy, I think some misconceptions might be it's a one-time treatment and you're done, or there's no side effects with it. With radiation therapy, you're delivering high doses of radiation. So when you understand radiation biology and how it affects the body, sometimes you can have sunburn side effects, or dryness in the mouth, or mouth ulcers, or GI issues. Depending on the organ that's being radiated, there can be side effects in the areas surrounding it. So it just has to be careful planning and coordination. And it is over multiple times.
Okay, thank
Hope
you.
that answers the question.
Thank you. Another question is about the length of shift. How long are the shifts at the hospital? Is it 8 hours, 12 hours?
Well, that's going to really depend on where you work. If you work in a hospital, we are open 24/7. People can get hired to do 410s, 312s. Some people prefer to work 5/8s. If you're in a hospital, you're typically always going to have a weekend and a holiday in there at some point, because we are always there. Physicians' offices, where I can tell you that the salary is going to be different, usually a little bit lower, because the criticality of the patients are different. Their hours might be Monday through Friday and no weekends or holidays. So it really depends on what that institution is offering. I don't know if you guys have anything different.
Yeah, we have a variety of shifts in all of our departments. Some are 10s, some are 8s, some are 12s, some are a mixture of both. It really just depends on kind of what you're hired in for at the time, what they have available. It can be varied.
Great.
And some modalities also have call. So you're working your shift, but then in addition to that, you're carrying a pager or your cell phone, and you could get called in if needed for cases that are emergent.
Very true.
Perfect. Thank you. Another question, how many days would a person right out of school usually work?
Well, again, that depends on what you're hired for. So when I got out of college, the only job that was available was part-time, and it was every Friday, Saturday, Sunday, and it was night shift. But I took it, it was a few years back. So it just depends on the positions. Kind of like if you apply for any job anywhere, it depends on what they're hiring. So hospitals, the one nice thing I can tell you about working in a hospital is there's always flexibility. Whether you've got kids at home or if you're going back to school. When I went back to school to get my master's, the flexibility was great. So if you're hired in at part-time, you might work 2 days one week, 3 days another, or it just really depends on the job and what's offered. But the hospitals do give you that flexibility due to the fact that we are 24/7 and we're open 365 days a year. So you right out of school, you could work full time if that position is posted,
when I got out of school, I worked a 0.5, which is a part-time as well. So I did part-time and I was evening, so I was 2 to 10:30. And then 2 years into it, they had a department restructure and I was put on overnights and I was 7 to 7, 7 p.m. to 7 a.m. So that was a change for me. And that's when I kind of started looking over into MRI. But the other nice thing about the hospital with flexibility is you have other staff members that are here. You know, if you work at a doctor's office, there might be one person that can cover your shift, whereas here you can trade with people, you can flex with people, you know, you've got a bigger pool of people to kind of help you out when you do have those times of need.
And, I have to say the other big thing when I went into it, I grew up with healthcare in my family. So, but is the ability of I could go probably move anywhere and there's always a hospital and you're always going to find a technologist job or radiographer. So I like that flexibility. Though sadly, I'm still in Illinois. I've never left. But when I was younger, that was my goal. I'm heading out, but so there's things to take like that it's a career that if you decide to move to California or to Europe or wherever, those jobs are also there too. So.
Great. And a question as a follow-up to this, when you move to a different state, do you have to take an exam in that state in order to practice there?
Typically, you have to just get your license in that state, which there's just paperwork. California and Australia do have different requirements that you would have to take a different kind of board. Nothing, that you don't already know. It's just their own qualifications. But most states, you just have to, like if I move to Montana, I just have to update my license so I'm available in Montana. But boards, not specific to additional ones. That's the great thing about the accredited programs is that you want to be in one. So once you're accredited by the ARRT, you can go other places.
Yeah, I think California, New York, and Florida had specific things, but I could be wrong about that.
Thank you. So what schools would you recommend in Illinois for this degree?
Depending on where you want to, what your goal is, Southern Illinois has a great 4-year program. Some of the community colleges local to here, I'm not sure everybody lives, but Harper College has a great program.
CLC has a program.
Mhm.
If you happen to be in the MCC area, I know MCC has a contract with CLC that you can go, since they don't have a medical imaging program there, you can go take it at CLC for like the same price. You do have to go into the counselor and ask them about it though, because there is some paperwork that you do have to fill out for it.
If you go on to, I believe College of DuPage might have a program, but if you go on to the ART websites, or even if you Google, that'll take you there, and then it'll give you a list of different colleges, whether you want a 2-year or a 4-year program.
That's aart.org.
Yeah.
Thank you. So why did you choose this specific profession? And a second part to that question, what's one unique aspect you like about your job?
That's a great question. I'm going to let all of us answer because we all have different reasons. So my dad was a physician and my mom was a nurse. So and both my grandparents. So I've been in medical field, has been my whole family. What I liked, and I've been around all of it about imaging, was it's different every day. And this is just my opinion. I didn't want to go to work and see the same patients in the same bed every day, which in some people in nursing, that's perfect for them. And I give them credit for all of that. I wanted more of a fast paced, I wanted challenge. I wanted everything to be different. And every single patient, whether you do 20 CT heads in a row, every single one of them is going to be different. And that's what I liked about it. I liked the technology changing. I liked the fact that 90% of the patients that come to a hospital, imaging is where they're going to start their journey to their diagnosis, to their healing, whatever their journey might be. Most people can't diagnose their patients without imaging. So I liked being on the forefront. I think the biggest thing was the change, ever changing. I like the flexibility of that I could work nights or PMs or days and whatever I want, part-time, or, and I you're always going to have a hospital. I think maybe because I was around it, but there's, businesses come and go, but hospitals are always there. So, and to this day, even though as the manager, I'm not in patient care as much, though I do go out there and take care of patients because I still enjoy it. Being around the teams and the patients is probably still my favorite part of imaging. A challenging patient and then being able to get everything that you need to get is very satisfying. So there's a lot of reasons, but I'll let everybody else. I won't.
Yeah, I can kind of mirror what Meredith said. I got into medical imaging because I wanted to do something in the medical field, and people always told me how great of a nurse I would make, and I didn't feel like that was for me. Again, reflecting what you said, I didn't want to go see kind of the same patient every single day and be taking care of the same person. With medical imaging, there are a lot of different options. There's a lot of different avenues. Even if you're an x-ray tech at our hospital, you're going to the ER, you're going to surgery, you're doing epidurals, you're doing outpatients. There's a lot of different, there's a lot of variety to what you're doing. It's not the same thing over and over, yet it is. So it was just the right career choice for me. I liked medical, and like I said, wanted something where, I'm the nice x-ray girl or the MRI girl that they see for an hour when they're having their time in the hospital, and then they go back up to their room. I'm like the little break that they get from their regular routine.
Sarah?
Well, I actually started out wanting to go to school to be pre-med. And then I changed my mind my junior year, and I spent an additional 5th year doing my nuclear medicine internship and clinicals. What I like the most about the field is just being able to talk an anxious patient through their test, and they feel so much better after everything's over because of how you explain something to them. And then it's also very satisfying to see a patient you saw 6 months ago with metastasis from cancer everywhere. And then you see them again for a follow-up scan, and you can see the treatment's working and their cancer's disappeared or it's reduced. And it's really neat to see that happening right before your eyes. And one thing that's really nice about Nuke Med is it's just being able to be on the forefront of technology where you are helping treat patients and seeing the effects of that treatment with targeted molecular imaging. It's pretty cool.
I would agree. It's very cool. Thanks.
Great. Thank you. Thank you. Next question. So Meredith, you did talk about what classes are recommended in high school to take to work in imaging services, but we have a question specifically to be an ultrasound tech. If there are any different classes that you should be focusing on.
Anatomy is probably the biggest one in high school. You're going to have your prerequisites to get into college no matter what you do. But if you're looking, an ultrasound is such a unique, amazing modality to get into. Not easy. I'll be honest. It's harder because you're not looking at organs in a way that you would with the ionizing radiation. Sound waves is a little bit different, but so much is satisfying with that part of it too. But anatomy would be probably the best one to take in high school for that, because that is going to help you when you get into the programs with it. I could say anatomy too for everything, but specifically with ultrasound too.
Wonderful, thank you. So a question about shifts and flexibility, shifts and schedules. Are they flexible?
Again, that depends on when you're hired, where you're hired. That's kind of per situation. At the hospital, we tend to be flexible with our staff when we can be. Again, we have a bigger pool of people, so we can kind of leverage people differently here. But there is flexibility when, if someone's leaving, you're the next one in line, you get to take over their shift. We have seniority. So
I think if you work in a smaller organization or you work in a physician's office, you probably have less flexibility because you might be the only technologist or the only ultrasound tech there, that type of thing. So again, I might have a position for a night shift CT, and that's what you're hired for. Not to say that they don't switch and come to days sometimes. So, it just depends on what you're hired in for, but down the road doesn't mean that you can't change if those shifts are available and open.
Okay, wonderful. And one more question. Are most radiographers female? Are more men entering this field?
That is a great question. I'll let these guys answer too. We probably have, yes, most are female. It's almost like if you compare it to like nursing, you're going to find most nurses are female, but you do have that population of male. I would say radiographers population of male is higher than nursing. But yes, again, most of them are female.
I would say I've seen a trend more in the last few years where there are more males coming into it, even in nursing as well, just in medical in general. I think men are kind of coming over more, not thinking it's.
Yeah, I think that's healthcare in general. You're seeing more and more men going into the field outside of being a physician.
Wonderful, thank you. And one more question. Did you go to medical school or a separate program? And how was your experience?
Oh, sure. So I went to a 4-year program, and then I went to 2 years radiology specific program. It is not medical school. A radiologist, which is an MD who goes to read the images or help perform the procedure. They go to medical school, they go to college, and then they'll go to medical school, and then they do the residency in radiology. So that is an MD. They don't perform the imaging, the exams. That would be our job. They collaborate with us for making sure we have the right protocols, so we know if you're here for a certain diagnosis, we're scanning exactly what they want to see. But yeah, we are not physicians.
Okay, thank you. So it seems like that was the last question. We have thank yous for the session. So what I wanted to close out with is the following, that if you are interested in learning a little bit more about what it feels like to be in imaging services, the great thing is though that we do have opportunities to volunteer with us. So if you are interested, by all means, please contact us. I'm going to put in a link to our application in the chat box, but you can also give us a call and I'll put it there as well. You can scan the code here right now and that will take you there. So many opportunities to volunteer and to see if it's even a field for you. We always encourage folks that if they're interested in exploring any careers in healthcare, volunteering at a hospital is a great way to see if it's indeed for you, to see what the environment is like, to talk to folks who work there firsthand to see what their jobs look like. So a great way to explore the career. And we always tell folks that if you, after that experience, decide that working in imaging services is definitely for you, that's wonderful. But it's as valuable as deciding that, you know what, no, that's not for me. I can cross it off my list because at least you won't be going into a field that you will later learn is not for you. So volunteering, a great way to learn about that particular field. And then also, we are going to be, we also recorded the session, so we are going to post it on our YouTube channel. And there is a link to follow. Again, also scan the code. I will also post it here in the chat box when we are done. Now, any other last questions? We still have a few minutes. Anybody would like to add anything? Ask any additional questions?
I would like to add thank you, Magda, for organizing this for all of us and asking to be a part of it. It's been a great experience.
Yes, thank you. It's great to brag about ourselves, but thank you for doing all this.
Yes, and thank you to all the students that joined the meeting, because I think it's great that you're exploring opportunities for your future.
Yes, thank you so much. And thank you for your time. We know how busy you guys are nowadays, just even more than at any other time. And thank you for taking the time to prepare and then also share your background. I hope that we have inspired some folks to think about that career, to explore it further, and then maybe you'll see them as volunteers and then later team members in your department. So again, thank you so very much, everyone. The best of luck in everything that you do, whatever you decide that you would like your career to be. We wish you all the best, and we hope to see you here either as a volunteer or a team member, and anytime we are here to answer your questions. So thank you so very, very much.